She has several lectures. The one for PIH, pregnancy-induced hypertension, and nope, I spoke. It is the one for high-risk perinatal care.
Miss Gabriel, I'm sorry. I'm so confused. I really do not know how to study for this class.
Okay.
Like, I don't know if I'm doing, like, I'm in the right area. I just don't know. I'm all over the place.
Why don't you set a meeting with me or Miss Love? I'll put a few more things on the calendar for myself, but I know Miss Love has several already up there. I personally am taking my exam tomorrow, so I didn't want any appointments before then. So I'll be available on Thursday and Friday if you want to meet with me. But Miss Love already has some up there, to my knowledge, and we can discuss that.
Okay.
Okay, so I misspoke earlier. So Ms. Wimsatt is going to come on and do the high-risk perinatal care. And I have it right up in this screen, and I didn't even look at it. That's on me. How did many of y'all watch the Maggie and Milo? Yeah. You feel like you learned anything or can remember certain things? Yeah, so it kind of just puts it all into a story. There's another one that I did an interview with Michelle for next week. So it just kind of runs through really quickly, but if you'll take that time to reflect on what's going on and why that happened. So she encounters infections, the baby has to be treated, all these types of things for postpartum. So their pregnancies went fine, but she had postpartum complications. So if you'll just, that might help also bring things together for next week. Okay. But she doesn't, she's a lay person, she's not a nurse, so she doesn't go into a bunch of details, and I didn't want to spend an hour on a recording. So interviewing her. So that's my 2 cents. So any questions before we do expectations of pregnancy? I went to nursing school with Maggie, so that's how I know her. Before she went into labor and delivery, she actually asked me about the hospital that I was working at because she was seeking that labor and delivery job. So referenced and stuff. Yep. Known her before she was married. And I know, of course, the person for next week. I wonder if you could guess who she is. Okay. So I am going to pull up a whiteboard. Does nursing school ever get better? I don't know how to answer that. You adapt and you can cope. You get better. Or that's the plan. Okay, so I'm going to start with GTPAL. So this is a whiteboard thing, and once I get done, it will create an image, and then I'll break apart the image for you guys as well. So don't freak out if I move on to an area and you haven't like taken a picture, because I'll post the pictures later, okay? Let me pull up the chat. Coping mechanisms? You mean coping? Maladaptive spiel. You're really tearing up the keyboard there, Melinda. No, this isn't a specific PowerPoint. This is some items that is not covered elsewhere. So I'll have these images available and put them on a PowerPoint with like the main items, but, and I will also make sure that today's session is broken up in recordings instead of one long 3-hour recording. So then you'll have one for expectations of pregnancy. I'll stop the recording and then we'll do another one for the application, and then I'll stop the recording and do another one so that there's 3 parts. So it's a little bit easier to manage and go back through. So what is GT palette? Has anyone come across this in their reading? Know what it is? It's an acronym. Yeah. Gravida, which is similar to gestations, how many gestations she's had. Term, preterm, abortions, and living. Yep. I'm gonna write that on here. So we have gravida, term, preterm, abortions. So this is any kind of fetal demise, stillborns, miscarriages, and then how many are living. So this can tell us a lot about her reproductive history, right? So if she's had a lot of miscarriages, if she's had a lot of preterms, if she's had duplicates, so twins, we can determine a lot by these numbers. So what they'll say in the OB world is they'll just list off G2, T1, P, and they'll just give a bunch of numbers. So what would it mean if this person is G2? Okay, bye, C. So she's had 2 pregnancies, right? So what about T1? What does that mean of those pregnancies? One was term, so then the other one must have been preterm, a miscarriage, right? So we're going to say that it was a preterm. So she had 1 preterm, 1 term, total of 2 pregnancies. So then she must not have had any abortions, and we're going to say both of those are living. Does that follow through with everyone? Okay. I didn't print this document. So, application. We have someone who is experiencing their 4th pregnancy. Her first pregnancy ended with a spontaneous abortion at 8 weeks. And the second resulted in a live birth. Second live birth of twins, born at 38 weeks. And the third pregnancy resulted in a live birth with a daughter at 34 weeks. Oops, there's a W there. Miscarriages, yes, are under abortion. So any type of stillborn, miscarriage, spontaneous abortion, or induced abortions. Okay, so in this scenario, I'm sorry you don't like that word, but it follows the acronym that all facilities use. At any point in the pregnancy. What do you mean? I didn't catch what you were referring to, Jamie. Like even after a few weeks. The abortion? So at any time if there is a fetus that has started to develop, so it could be even a first trimester abortion. She has started a gestation in her pregnancy, so it would count as a gestation and an abortion. So if someone has had a lot of miscarriages or abortions, they might have some scar tissue, some issues with carrying a pregnancy to full term. So it's something that we would like to know. So with this scenario, let's do green. So we're on our 4th pregnancy. So where are we going to put this 4? G4T2P1A1L3. Let me scroll back up. Let me see that. Yeah, good job, Wood. All right, so we're going to break this down. So where's my little mouse? Okay, so this is her 4th pregnancy. So she's currently pregnant. So we're going to do 4 here. The first one ended at an abortion at 8 weeks. So that's going to be 1 gestation of an abortion. Second live birth was twins at 38 weeks. Is this term or preterm? Term. Thanks, Jimmy. My light went off. So that's 2 fetuses. So we're going to have 2 there. And then another one at 34 weeks. Is that term or preterm? Preterm. So that was 1 baby that was born. And they were all live. So how many live babies do we have? Three. Yep. So then that is your scenario, your situation there. Oops. I'm going to do another scenario. Why isn't T going to be 1? So T is how many babies came to term. So it's not how many pregnancies, but she had twins. So two babies were born at term. So then you get, because of the twins, the 2. That's why I wanted to do the twins. All right, so another scenario. I'm going to do, I guess I should have done that in red so that it's the same color. I'll fix it so that you can see it later, which one is which. Oops. Okay, so now we're going to do a green scenario. So some of you may have already had some of this in immersion day, but that's for clinical. So I want to make sure everyone's on the same page for class. Yep. All right, so another scenario. So we have a 6-week pregnant mother. Her previous 2 pregnancies ended in a live birth at 41 weeks. That's all you get for this scenario. So what's our GT-PAL going to be? How many pregnancies has she had currently? 3. Okay. And how many have come to term? Mm-hmm. And preterm. 0, 0, and 1 living. Wait, that doesn't make sense. That's the answer key that it gives me though. It says previous 2 pregnancies. So I would say that this is 2 and they were both live. So this is what my answer would be. If they didn't put that 2 in there. Yeah, so G3T2P0A0L2. Let me make this cleaner. Yeah, it makes sense now. All right. Any questions with GT-PAL? You probably need to keep practicing it. Make sure you understand it. Don't forget about it.
Ms. Gilbert, I have a question real quick.
Mm-hmm.
Just to kind of clarify, if a woman is pregnant with multiples, that's still only counted as 1 G mark?
1 G, so it's still 1 pregnancy, and
Okay.
then the rest are how many babies.
Okay.
So babies that were term, preterm, that were aborted, or living.
Okay, gotcha, thanks.
Mm-hmm. Any other questions?
I have a question to clarify the term abortion. Abortion can be either like a mechanical abortion where that's like intentional,
Mm-hmm.
or like a miscarriage where it's spontaneous.
Right, or stillborn.
A stillborn is considered an abortion as well?
Mm-hmm. In this scenario, so not in the term, but for use for this acronym in the hospital, anything that's not living would be non-living. So anything that's not living when it was born.
Okay. Okay, thanks.
I mean, I'm checking the chat right now. Hold on.
So how about if a baby was born live, but wasn't quite viable and died, within a few hours or something, is that still considered an A mark?
I think it would be considered living, but they would definitely have that in the chart that it didn't survive long.
Yeah, the information in the chat's what confused me, because it said kind of, and that's why I'm asking for clarification, because so even if the fetus is not born alive, it is not considered an abortion.
No. If the fetus is terminated for whatever reason, so it could be a natural reason. A lot of times women actually have miscarriages, which are considered abortions. The problem is, I think that when we think abortion, we think of someone intentionally ending the pregnancy.
Abortion is a
But
umbrella
it
term.
has to do with the ending of a pregnancy for whatever reason. It can have multiple reasons. And to answer, to address Jamie's, so I had a pregnancy that terminated spontaneously at 19 weeks. The child was born alive, so it wasn't an abortion. She was born alive, but because she was 19 weeks and was not viable, she died afterwards. So she died very shortly after being born. So it wasn't an abortion. If she died prior to delivery, it would have been a spontaneous abortion or a miscarriage. So abortion has to do with the termination of a pregnancy prior to delivery. If the child
It does not
is
have
delivered,
to be intentional.
right, it's not
miscarriage.
necessarily intentional. It's just any termination that occurs prior to delivery. Once the child is delivered, and if it's alive, then it's a live birth. So even though my baby died, from my understanding, within a few minutes, she was born alive. So that was a live birth,
Mhm.
if that makes sense. But
Okay, so an
if
actual
she,
still,
go ahead.
I'm sorry. So an actual stillborn birth is considered an aborted birth because the baby was actually born deceased.
Right.
Yes.
Okay.
So
I
in this acronym, that's what a stillborn would be in the A.
Because
so-
it terminated prior to delivery.
Okay, I got it. Thank you.
Mhm.
You're welcome.
So one more question. I actually have a sister that was born that same way, and she died shortly after she was born. So would that child be given an L mark too as living?
If she was born initially alive, yes, and died after birth, it would be an L.
Okay.
At the time of birth, if they were alive or not alive.
Okay. Thank you.
Mhm. Okay. So now,
About how Miss Love was saying there was a baby born at 19 weeks. Why would that not be under the preterm? Why would
It would be.
preterm and term would have also been calculated,
Yes.
but we were only referencing the A and the L. But yes, it would have been counted as a gestation, a preterm, and then a living.
Okay, gotcha. Thank you.
Mhm. Thank you. Okay, so now next is Nigel's rule. So this is us determining the estimated date of delivery, so her due date, based off of her last menstrual period. So we're gonna, of course, need to know her last menstrual period, and what day it started, the day that it started. So we're gonna add a year, subtract 3 months, and add 7 days. And that will give us our estimated date of delivery. So if our person's last menstrual period was September 4th, 2006, what? What do you mean, Melinda? For Nigel's rule?
Apparently I can't type this morning, so it just sounds confusing. That's all. Thanks.
For what?
Nigel's rule sounds very confusing.
I'm gonna
Plus
show
1
you.
minus 3. Okay, thanks.
So you're going to take these pieces and add it to the date. So this is the month. So we're going to minus 3 months. And the date, we're going to add 7 days. And then the year, we're going to add a year. So what is September minus 3 months? Yes. 9 minus 3 is 6. Yeah. So June. 4 days. The 4th day plus 7 days is the 11th. And then 2006 in a year is 2007. So if this was her last menstrual period, she would be estimated due date of June 11, 2007. Now does it make sense, Melinda? You're going to separate these. Don't think about it. I mean, you could add 9 months and so many days, blah, 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 but Nigel's rule is a little bit easier. Yes.
I have a boy question about girls. How do you? I mean, did I get? And I know I'm sure women just know, they can tell you like what day, but like what? I mean, is it like when they start their period as far as like when they start spotting or bleeding? Is that when
So
the
yeah.
last?
So we're gonna take this date on their first day of their last period.
Okay.
So whenever they started their menstrual cycle.
Okay. Thank you.
Mhm. Because everyone's cycles can be a little bit differently. Could be a 4-day cycle, 5-day cycle, 7 days that they spot or bleed. So the most accurate is that first day. So we're going to take the first day, but then we're going to adjust by a couple of days too. Melissa, we usually know. Yes, it is not something that is not noticeable. You know what it is. Okay, so let me find another one. All right, so let's do green. Oops, back out. So if our last menstrual period was February 26th, 2019, what is our estimated due date now? Leap years are in the divisible by 4. So that's not a leap year. Good catch. So February minus 3 months is December, right? Wait, no. You don't count the month. Am I doing this wrong? Hold on just a second, guys. Okay. So I was wrong. So you count the month that it's in. So 9, 8, 7. So this would be July. So then I was thinking right on this one, but not the other one. So this one is December. So September is 9. So 9, 8, 7 is July. 2, 1, 12. And then 26 and 7 is 33, but there's only 27 days. Yes, so we're going to count the month that it starts. I did not do that before on the red one. And that's my bad, because even my little answer key thing over here says July. And I saw it in the chat and ran with it, but I'm sorry. So 33 minus 27 in that month. So December 6th, 2020. So you would take September, which is 9, the 9th month, minus 30. So 9, 8, 7. You would count it to get away from, you're not like actually subtracting to 6. Yeah, so 2019 plus 1 year, oops, would be 2020. Is there 28? Oh yeah, on leap years it's 29. Okay, so that's my bad again. So 20, 30, I just made this one up. I don't have an answer key for me. So this is my bad. So 33
I have a
minus
question really quick.
28. So this is the 5th. Yes.
Okay. But think about that. If she's pregnant in February 26th of 2019, that's a really long gestation. So wouldn't it still be 2019?
Probably. That makes sense. Probably because we went backwards in this year already.
Right.
Again, I said I just made this one up.
Okay, I'm just checking.
So if 2, 26, 2019, calculate. Nope. So 2019, December. Yeah, right. I'm sorry if I confused you guys with that one. I was just going off everything else. All right. Do we need to do another one so we're not confused? Okay. Let me pull up my document and figure out another one. All right. So that one's very similar, but we'll go with it. So if her last menstrual period is September 19th, 2007. Right. Pregnancies usually only last 9 months. Usually, hopefully. So minus 3 plus 7 plus 1. So June. Wait. Why is this one June and the other one's not June? It's keyed that way too. That one's keyed as July. And And this one is keyed as June. Let me find another one. I don't like this worksheet that I found online. Okay. Let's do February 12th, 2006. Oops, minus. I am not having a baby. So December 19th, 2006. Because we went back. All right. That one was better. All right. So quickly go over nutritional needs, and then we'll go through pregnancy, first, second trimester, third trimester, and postpartum. So someone that's pregnant now has a whole nother living thing to feed. Their blood supply increases almost twice their normal blood supply, vasculature, than before they were pregnant. So there's a lot more going on, and that's usually what leads to the high blood pressure for those who have pregnancy-induced hypertension, because of the increase in vasculature, the increase in blood volume that's in their body. So increase in all of that, they also have an increase in workload. So they're going to need additional nutritional needs, but it's not as much as many people think. So how many more calories do you think a pregnancy person needs? More than the adult, regular adult. $2,000 more calories. Now they're going to be shocked. In the first trimester of pregnancy, there's no additional need. In the second and third trimester, their need only increases by 300 to 400 calories. Shock. Now you get those cravings and you want that, but you don't need that. Hormones, Mike. Hormones.
I think in my wife's first trimester of pregnancy, my calories went up like 2,000.
Mine has gained weight too. So, all right. What about iron? That increase in blood, you need more iron so you can carry all the oxygen, right? So how much more iron do you think someone needs compared to the average adult? Enough to make you constipated. So as the pregnancy progresses, they're going to need double because their blood volume is doubled, right? So it's the same. So they're going to need double their normal iron intake, which, if you think about it, the average person nowadays actually eats more calories than they're supposed to. and they don't have enough iron, folate, and fluids in their diet. But then compared to what you're supposed to get to when you're pregnant, it seems like a big jump because that's not your normal, your day to day, but you're living day to day deficient. So to catch up, it seems like a lot. But your iron, due to your daily nutritional facts that you're supposed to get, your need during pregnancy doubles. And then folate. Oh, so what are some iron-rich foods first? Oh, spinach, greens. What about meat? Liver. There's another one. Really big. Tuna. Tuna has a lot of iron. Tuna fish. All right, now folate. Why do we need folate? What does folic acid do? Brain, yep, it prevents neural tube defects in the infant. So then compared to the daily nutritional value, how much more a day? Well, not more per day. The average person is supposed to get 400 a day, 400 micrograms, but most people don't have that in their diet. But it's important during pregnancy that they get 400 to 800 micrograms. So most prenatal vitamins will have folic acid in them. And that's why they're different from just regular women's vitamins, men's vitamins, because they have this higher dose of folic acid in them. So it helps the neural tube develop correctly and prevent those defects. So that's very, very important. 400 to 800 a day. All right, and then fluids. What's your expectation of fluids on a normal non-pregnant adult? Two to 3 liters, yeah. So about how many glasses or cups is that? 8 cups. So again, most people don't do that. So the pregnancy lady needs at least this much, but preferably up to 10 glasses of water. If they have that extra blood volume, they need to stay hydrated, right? This also helps develop the amniotic fluid so that there's enough room and fluid in the amniotic sac for the fetus to grow appropriately. Okay. Any questions over those? Those are the main ones that I wanted to make sure we covered. And that's glasses.
So for the only really different change between trimesters is the calories in the first trimester. You really don't need any extra.
There's
everything else is kind of the same throughout all the trimesters.
Right.
Okay.
The important thing though with the calories during the first semester, there's no new need, but a lot of pregnancies have that morning sickness in first trimester. So they're actually getting less than they need. So they may need to increase during their non-nauseous times in order to meet that still daily caloric intake. Then their second and third trimester, which I'll get into up above here, is that when those morning sickness and things start to curve and they're able to start taking back in their nutrition. All right, so try and get this all on one screen, but I might have to zoom in between. All right, the last section I wanted to go through was kind of the progression of pregnancy expectations, so like a normal pregnancy of certain things that happen in certain orders, certain things may or may not happen, but if they happen at a certain time. So this is what we're gonna, ooh, I didn't even know I could move things. So starting with first trimester, what do you guys think is the first thing that happens? How do you usually think that maybe you might be pregnant? No period, missed period. So what's the term for that? When you have no period? Amenorrhea. Make sure I'm spelling it right. Right. Okay. So then, so I'm going to kind of go in order of things. So I'm not trying to ignore some of the things that y'all are saying. I'm going in a specific order. So the first thing that usually happens and noticeable, that is a true sign of pregnancy, whereas like breast discomfort, there's malaise, they are general signs, so they may be indicative of something else. That doesn't necessarily mean not that you are pregnant. So usually one of the first true signs of pregnancy is going to be amenorrhea. The next sign is going to be Goodell's sign. Does anyone know what Goodell's sign is? Goodell's, I don't know. The areolas happen later. So Goodell's sign is the softening of the cervix. So this is one of the things that they'll check on your first appointment. Okay. Third sign is going to be Hager's. Ooh. Hager sign, which is the softening of the uterus. And then you have linea nigra, whatever. Happens in some people, but not everyone. But this is usually when it will start happening. What is this? So it's a dark line that is vertical. So it goes down like this in their belly. And this is their hips. I don't, anyways. There's their belly button and it goes down the center of them. The dark line that goes down. Let's see, pull it up for the picture. So yeah, that dark discoloration happens. They don't really know why it happens. They assume it's due to the hormones. It will go away after pregnancy is finished. And then striae gravidarum. What's that? Stretch marks. They can be dark, they can be light, they can be red. It's just the stretching and the hormones filling those in. Okay. So stretch marks. So this is usually the last sign, right? Because you don't really start showing till the end when it starts getting larger. Okay. Second trimester. So these ones aren't really in order. They're just kind of like, blah. So we have quickening. So these happen, but they can be kind of out of order. What is quickening? Oh, go away. Go away. It's like the butterflies in your stomach. And so it's the little fluttery sensation. It's the first little fluttery movements of the baby. It may not feel like kicks that you will hopefully feel later, but it's the first little fluttering sensation. Next, you're probably going to have some spider nevi. Not everyone gets these. So it's the little blood vessels on the stomach. They start popping up, look like a little spider web. I had 2 of these on the same side. They can happen on your belly, and some people do get them on their face. Usually it's on their belly though. So, I don't know, what do you want to call this as a description for spider nevi? Spider web? Webbing? Can you get them on your face and they never go away? Usually they go away, to my knowledge. The ones on my belly went away. I don't know. I know, isn't pregnancy beautiful? That the spider angioma is different. And so they can look similar, but it's actually indicative of like liver things usually. So, I don't know. And then what happens in second trimester usually is we get supine hypotension. What does that mean? Okay. Blood pressure drops from lying on your back. Why? Yep, pressure on the vena cava. So the mom that's laying down, there's the baby puts pressure on the vena cava and cuts off blood supply. So decreases the blood pressure of the mom, and if the blood pressure in the mom decreases, what's going to happen to the baby? It decreases the cardiac output. So then there's decreased perfusion to the baby. So this can be quite harmful. This happened several times with me, and then once I got to the 3rd trimester, I was no longer allowed to lie on my back ever because it was causing decels. Because of severe hypoxia to the baby when I laid on my back. And then we have orthostatic hypotension. How does the man in the group know all these women things, Jamie? Oh, I didn't see that you came back in. Yeah, hold on. There you go. Thank you. Sorry. I thought I had my participants open. I guess not. So what is orthostatic hypertension? How is that different? Yep, so the blood pressure drops when they stand up. We think about it, you have twice as much fluid volume, and that sudden shift, standing up too fast or just getting up from the bed, everything shifts so suddenly that you get dizzy. You can pass out, right? So this can be also harmful to the mom and can cause the decreased perfusion as well to the baby. So gotta be mindful of that. So even without being pregnant. Yes, but we're talking about pregnancy. So if this happens frequently or even just one time, they'll give her education, you know, to sit up on the side of the bed slowly before getting up, transition slowly, all those, you know, interventions, education, right? And then cholasma can happen. What is cholasma? It's called the pregnancy mask. I spelled it wrong. So you get this pigmentation on your face. Can even get really dark on some people. So in English background people, it will be pinkish sometimes instead of this darker color. So it's that flushing look that a lot of people will be like, oh, you're flushing from pregnancy, but it's a discoloration, the pigmentation on your face due to the pregnancy hormones. Not everyone gets this. And some people it's very light and just look, it can come and go. It doesn't stay on some people too. So if you're hot and bothered, you'll kind of get really pink in your face. This is similar to the cholasma. Okay. All right. Yeah, the pregnancy glow, the face, the pregnancy mask. So it can be different colored based on skin tone. All right, so second trimester, we're starting to show, right? We're starting to have a belly. Of course, these things are there. They're probably getting darker. Your areolas are getting darker. All that's starting to happen. So now third trimester, we're really feeling like an elephant. So what happens when we're have a big belly? What happens with our center of gravity? It shifts. So then what can happen to our spine? It curves. So yeah, back pain. So lordosis can happen. Remember which way lordosis was? Inward curve. So she's holding the belly out because the center of gravity. So then this inward curvature of the spine can happen, right? Yeah. So you got your hips, you're sitting back, and it can shift your spine this way. Okay. So third trimester, these are going to kind of happen in this order. So if it happens, it's going to be in this order. pelvis is what I should say. So then in that position, what is our neck doing? Why is it hurting? Yeah, so it shifts back. So it's called anterior neck flexion. So if you're shifted back, your head is going to jump out, like your back, but your chin is kind of going out in order to hold that position. Counting, right? So next we're going to have lightning. What is baby drops? So before the baby was all high up in my diaphragm, now the baby's gonna drop and settles down to the pelvis. So this is like those old wives' tales that, oh, you're not going into labor until after you drop. So the term here is lightning for when the baby begins to drop. It also go head first, right? They shouldn't be breech when they turn. They should turn and drop. So when the baby drops, what's that going to do?
I got a quick question about the lightning. So does the baby like turn and drop at the same time?
Mm-hmm. It happens over
all
a
happens.
couple of weeks, about a week or a couple weeks. Just
Okay.
it will start to turn and then drop.
At what point would the doctor or midwife like turn the baby manually if they haven't turned already?
Good question. I was 29 weeks, but she had been stuck in my pelvis the entire time, so they were doing it early. Most people, they wait until term about 32, 34 weeks, because once you're becoming term, you could go into labor at any time. So if the baby has not turned around, they don't necessarily have to drop yet, but they're supposed to have flipped first. And then if they haven't flipped, then your risk is to go into labor with a breech baby. So I got the manual version done. Most excruciating, painful thing in my life. And I had a C-section, and I've had cardiac ablations. I've had all kinds of stuff. And no, this was the worst thing ever, just the aversion. There's the risk of rupture and preterm labor, of course, with that manual manipulation. So 2 OBGYNs are involved. So one GYN is feeling inside of me from the outside through my stomach, finding the baby's shoulders. The other one is finding the baby's hips, and they are pulling and trying to move the baby from the outside of me. I had bruises on my stomach. It's all external because they don't want to stimulate anything to cause that. No epidural, no pain medicine, no nothing, because it can also injure the baby. So that was without any help. It's also a small room because we did it in the labor room, and because in case I went into labor. So the only part of my husband could be there and hold me was hold my big toe. And she did not turn. She stayed in my pelvis after all of that. They tried 4 times. So then we had to schedule a C-section.
So
I don't know why. She grew bigger and bigger, but never got out of my pelvis, so she got stuck. So she was even, after birth, her legs stayed up here in the same position as they were in every pregnancy. ultrasound. Her legs were
Did
just
you
up by her
did you
feet.
say that your husband could only hold your big toe?
Mm-hmm.
Oh
So
my.
clenching the sheets and couldn't hold his hand, can do nothing. And he just got to sit there and stare at me while I'm screaming in pain and holding my big toe. It was. I'm
And they
glad I did
can't
it
give you
because now I
anything
know
for
I did
pain?
everything possible for her, but it was very painful. And don't get any pain medicine, and you can potentially go into labor. So I was on bed rest afterwards, of course, so that I didn't trigger labor because of the stress that was put on my uterus.
Oh my. I'm scared. Thanks for that.
Well, most people don't have to do that. It's very rare. So actually my OBGYN was one of the few in the practice, and she had to find someone else that was experienced in it so that they could, because you have to have two. So she had to find someone. So I couldn't even do it in the next day or so. She had to find another obstetrician to do it with her. So it happens very rarely. Don't count for it. I opted for it. So. Then after lightning, okay, so lightning is the baby falling down into the pelvis. So if the baby goes into the pelvis, what's it on? The bladder. So we have urinary frequency again. So this usually is in first trimester as well, but this isn't due to the baby. This is due to the increased blood volume. So your kidneys are working in overdrive, right? So then you're peeing more frequently. It usually resolves here. And picks back up in third trimester. So it happens in first and third. Okay. All right, now that the baby has turned, dropped, and I'm having to go to the bathroom all the time now, what might be coming soon? Labor. So what is my body going to practice for labor? What are those called? Practicing. We're going to practice some contraction. Those are called Braxton Hicks. So these are practice contractions to get those muscles warmed up. Practice contractions. And then, so now that we're getting prepared, the last thing before labor, what happens? You start nesting. So this term is actually called surge or surging. So you get that surge of energy right before you go into labor. And so again, it's practicing the increase in endorphins, hormones, right before you go into labor. So your body is practicing again. So practice hormones. And then, so then you get everything right and ready for the room. You get your bag, you're paranoid, thinking, going crazy. And then labor and delivery. And there's a whole other lecture by Miss Winstead on that later. All right, so the last part is the postpartum. This is in black. So after labor and delivery happens, we're in the postpartum unit. What are we going to expect? Pain, yeah. sleepy. Are we gonna see some blood? The baby's on the outside now. Yeah, we're gonna expect blood. So the post-pregnancy blood is called lochia, and it's gonna progress in a certain order. Okay. And I had a pretty picture. I closed out of it. Let me see if I can find it. Let me see. Mhm. So, what happened to blood stain pads you did on immersion days? They're in the lab. I can bring them after a break and I can show them to you. So first it's going to be a rubra, which is this dark red, like a period blood. But then it's going to progress to a pinkish red, thinning out, called lochia serosa. And then lochia alba is going to be that white. So that's going to be up to 6 weeks afterwards. I'm going to write those on here too. So it starts with rubra. And it goes to serosa. And then goes to alba. Ooh, I licked the button. Let go. Stop it. Stop it. Alba. So this is dark red. This is pink. Oops. This is white. That does not look like pink. Okay. I wouldn't focus on the time frame. It's just postpartum. So day 1 to 6 weeks. It's going to progress that way because it can kind of go back and forth. So it can be dark red, go to pink, and then go back to dark red. It kind of whatever. And so then if you think between pink and white, it might look brown or infection looking. So as long as there's no odor, no mucus, no like green discoloration, then everything should be fine. But there's education to let them know that some people with their first pregnancy, they don't know that this is going to change. And it looks weird. Okay. So this is, lochia is the type of blood. And then you have your bleeding. So your amount of bleeding. Now, I also have these on pads. This is very blurry. Yeah, you're going to have moderate to heavy very beginning for a pad or two, but then it should slow down. So once you've come back to kind of now your new baseline, you should not have large amount. Okay, so then if we have a saturated pad in 20 minutes, what should you be concerned of? Hemorrhage, right? if I have a moderate pad in 45 minutes? What do you think? It should be okay, but I'm gonna make sure I keep checking that, make sure it doesn't progress. So clots, good question. So clots are gonna happen. So that's part of the blood just begins to clot before it comes out. So you're gonna have large amounts of clots. I mean, you can have large clots. If you have a lot of large clots, then you should be concerned. You should only have, I think they say like maybe 5 clots in an hour. If you have more than that, then you're bleeding so much that you're having a clot to stop the bleeding. So then it's a process. So you should not have 5 large clots in an hour. Okay. All right, what about breast milk? When should breast milk come in? Not the colostrum, but the milk. Yeah, 3 to 5 days. Most people, it's very quickly. Mine came in before I was discharged. But definitely by the 5th day. If they're not by the 5th day, they need to contact their physician. And of course, supplement their baby because they're not going to produce colostrum forever. And colostrum is not what the baby needs after that period of time. Their body has kicked in, it's moved on. They need more nutrients now. Okay. What about their fundus? What is a fundus? Upper part of the uterus, yep. So should, in the postpartum area, we're gonna go feel it and you're gonna see a term for boggy. Oops, not body. Boggy and firm. What does a boggy fundus mean? Right. So we want a firm fundus. So firm, so this is the uterus, right? It's really a big inside muscle, right? So we want a firm muscle. And so if there's nothing inside of it, it should just be muscle. If there's something inside of it like blood and clots, then it's going to feel boggy. It's going to feel really soft. So how do we get the blood and the clots out? You're going to push on it. So you're going to do a fundal massage. You probably won't do this, but you need to know a Franklin's. All right, so this, yes, ouch, it is very painful. I was quite drowsy after my C-section and the nurse came in there. I remember her saying something. I don't remember what she said though. And then all of a sudden she was pressing on my belly and I was fully awake. It is quite painful at first, but apparently I was having some large clots. And so she was making sure that my fundus was firm and not boggy. So it's a lot of pressure. You have to massage it. You have to push it back down. Okay. So what if the fundus is displaced to the right? if it's not midline? Why would it be over to the right side? A full bladder. So if it's moved over to the right, it can be a full bladder. So what are we going to ask her to do? Go urinate, please. And then I'll recheck your fundus. Okay. All right. So if I found a boggy fundus and I massaged on it, it's feeling a little bit better, what am I going to expect to be on her pad? Yeah, bloody pads. So we should expect that at first because we just pushed all these clots out, right? But when I come back in an hour and it's saturated again, I need to check the fundus again. So reevaluating, right? So why is the bladder to the right? That's a good question. Let me fix this. So anatomically, boggy. So anatomically, your bladder is kind of there in the middle-ish, and then you have your uterus that's on top of it, but it's not really centered. It's mostly centered, but not really. But then, and when this bladder fills up, it's gonna go and fill this side, and it's gonna push your uterus over. So just when the bladder gets full, it takes the more centered position because this is more attached to ligaments and things and is more in place because it's always there. Whereas your uterus is growing, and so it's more pliable and movable. So it's going to move out of the way. Your bladder's not going to move. So the uterus gets pushed. Okay. All right. Oh. Speaking of breast milk, when should or what should the breasts feel like on assessment? Not really left. It should be midline. There's some other things that Miss Wimsott might know about a left. Right side is the only one that I'm aware of. Right. But it would be a good thing to ask her when she comes on a little bit. We're almost done and we're going to take a break before she comes on. So you can save that question for her. So even before milk comes in, when the colostrum comes in, what the breast should feel full term and hard is another word for firm. So hard is not saying mastitis hard. Mastitis is a subsection that is harder than another. Why? What is mastitis? It's an infected, yeah, milk gland. So it's blocked up. It's blocked up and it's infected. So this is going to be hot, not warm. So this is warm is going to be normal. Hot is not. Hot, small portion that is hard and the others are soft. It's going to be an area that is different than the rest. If the whole breast is firm, hard, and warm, that's okay, right? So there's the difference there. It should not be pain. Oh, mastitis. Yes. Mastitis is painful. Oops. I am apparently clicking again. Painful. Okay. I can't do this with a pen. I can't do the mouse. Painful. Yeah, so that area, because of the infection, especially after a day or so, is going to be reddened on that spot. Good job. All right, I'm running out of room. I didn't think it would take as much space, but last two things I want to talk about are postpartum depression and then the cord. So what kind of things are we looking for with postpartum depression? Not connecting with the baby. So they're not attaching or bonding. So what are some indications of someone actually bonding or attaching to their child? You know, holding, if they have the baby face to face with them, not out and don't know how to hold the baby. They're not bringing them in. So those kind of techniques that be mindful of if it's still not personalized versus taking in, they have developed a personal connection with them. So if they're not attaching or not bonding, then we might want to be concerned about postpartum depression. They're not caring for them. They're not changing their diaper right. If they're, say, this baby doesn't look like me, I don't know this baby, they're not developing or trusting or wanting anything that indicates those negative behaviors. So who is more likely to develop postpartum depression? Right, Holly. So if you already have a history of depression, you're likely to have postpartum depression. So postpartum depression is different than postpartum blues, though. Okay. So you need to make sure that you understand. So postpartum blues is temporary, doesn't usually lead to harm. Not that this always leads to harm, but it can lead to harm. But this doesn't usually lead to harm. But you have to be mindful of it. You need to give them some coping mechanisms. And you can usually recognize this in the postpartum at the hospital. This kind of got earlier signs. Whereas postpartum depression may not have drastic signs because they can kind of put up, people with depression, you put up a mask, right? So they can mask this in the first initial postpartum area, right? And then when they go home is when more things happen, when you have more concern. And so this is where more education is for the family, the caregiver, their support. You need to make sure they have a support system. Okay. So then what kind of interventions are we going to do for the room in the postpartum area if we are suspecting maladaptations? Go. Safety measures, right? So, safety, sidewalk, ideations. So you're going to remove anything that might be harmful, that could be cause for patient demise, fetal demise, making sure that you're checking on that baby is not left alone with the mom at any time, things like that. Okay, last thing, this one, let's talk about somewhere else. Is the umbilical cord. What does it look like? After the baby is born, they cut the cord. We take a look at it. What does it have? It'll turn white because there's no longer blood going through it, because it's clamped. It should have 3 vessels. So 2 are arteries and vein. So if you only have 1 and 1, it's a 2-vessel system, which could be fine. But if you have half as much arterial flow, you could get with a decrease in perfusion, right? And so that you could have hypoxia concerns for the infant. So that is talked about in Maggie and Milo's video, but again, we said they weren't required. I do think they were beneficial, but it can be triggering. So I just wanted to make sure that this was talked about elsewhere. And I think it was in any of the swim stats. Okay, any questions? Look at everything we did today. Yes. Go back. Where did you do that? Where did this come from? Here, form. I felt like instead of a PowerPoint describing these detail Nigel's rules and progression might be a little bit better. So this is going to be fun. They started overlapping each other. I'm going to take and break apart these things as well. Put them on a PowerPoint for you. Okay. Umbilical care. We talked about some in the newborn area last module. So making sure the belly, the diaper is folded down, not rubbing up against the umbilical cord, and it should fall up on its own within 2 weeks. So not be messed with. And the clamp will come off before discharge. Thank you. All right. Any other questions before I stop this portion? Thank you. I know I bought this thing for the whiteboard a long time ago and I haven't been using it lately, and I'm like, let me get back to my roots. Yes.
I got a quick question. Let me think of it. How long after the cord is cut and clamped does it take to heal enough to remove the clamp?
The clamp usually comes off about day 2 or 3 before discharge. So it should be no longer perfusing and therefore risk for bleeding when it comes out. Usually within a couple hours, it'll start to die off towards the end, but we need the rest of it to die off on its own. So
are there like certain signs or
it'll get really opaque, clear looking, and it'll get really flimsy and dry, and they'll just kind of flick it to see if it's going to fall off soon or not. And then if it's looking okay, then they'll take off the clamp. So signs that it's not being perfused anymore. That's dying
At what
off.
point does it lose a pulse?
On the other side of the clamp immediately.
Like as soon as it's,
it'll still have a pulse.
I mean, like, ma'am.
It'll still have a pulse underneath it before it dies off, but actually that portion of your umbilical cord that's still there even after it falls off can still be accessed. I've done that trauma. I've had a pediatric emergency physician with me during a trauma who a 3-day-old infant came in and he accessed, we couldn't get a vein. He accessed the umbilical cord and got a central line.
Oh, wow.
So it was still obtainable. So that was quite a sight to see.
Cool. Thank you.
Tiny little vessels.
Yeah.
All right. I'm going to stop this recording, and then we are going to take a break until Ms. Wimsatt comes on. I don't know what happened to my thing. There it is.